Good afternoon, everyone. Bancroft Neurorehab welcomes you to our Heads Up webinar series. Today's program is Visual Dysfunction After Brain Injury. If you have a question, please type it into the chat area to the right of your screen. We'll have time at the end of the presentation for Q&A. And now I will turn the presentation over to today's speaker, Katie Bartholomew, who is an occupational therapist at Bancroft Neurorehab.
Hi, everyone. I'm Katie. Thank you so much for your time this afternoon. As Stephanie said, we're going to be talking about visual dysfunction following a brain injury. I did include my email on here, so if you guys have any follow-up questions after the presentation, please feel free to reach out to me. There's going to be a lot of information we're going to cover at a pretty quick speed, so hopefully there's plenty of time to answer questions at the end, but if we do get kind of cut short, feel free to reach out. So I have no disclosures or nothing to disclose. So following this session, I'm hoping that you will be able to understand the visual system and the diffuse impact an acquired brain injury will have on visual function, be able to identify the signs and symptoms of visual dysfunction, and referral recommendations based on the level of impairment, describe the methods of evaluation for vision impairment and dysfunction, and then explain treatment options for visual dysfunction and identify treatment protocols that are currently in place for vision therapy. So as we know with the visual system, it obviously includes the eye, but beyond there, there's a whole lot that goes on in the brain itself. So quick anatomy review, just so we can really appreciate kind of what goes on in the brain. So once the information is received through the eye, these two pictures are depicting what then happens at the level of the brain. So the left picture, they're essentially saying the same thing. The left picture looks at things a little more anatomically, whereas the picture on the right is going to highlight a little bit more functionally. So if you see the red and the blue, that's kind of indicating where the visual information is in someone's environment, and then how that information is then taken in via the eyes and then the optic tract. So that being said, you know, the real importance here is just understanding how diffuse the visual system is and how much of our brain it's going to travel through to really be able to appreciate an injury in any area of the brain, what kind of impact it could have on someone's visual skills. So following the information being received through the eye, it's going to be taken into the back of the eye where the retina is, and then into the optic nerve. From there, it's going to travel along the axons and then divide at the optic chiasm, which is this X right here. And that information from the left and the right sides of the eye does split and cross over. And then from there, it's going to travel along to a few different vital areas that are highlighted on the left picture, either the hypothalamus, the protectum, or the superior colliculus. And if it continues to pass through, it's going to then all be integrated back in the occipital lobe, where our primary visual cortex lives. All right, so in terms of the muscles of our eyes, we have 6 total muscles that control the movement of our eyes. And they are innervated by 3 different cranial nerves. So that's going to be cranial nerve 3, which is our ocular motor nerve, cranial nerve 4, which is our trochlear nerve, and cranial nerve 6, which is abducens. And together, these muscles are responsible for moving the eyes up and down, inward and outward, and rotating either away or towards the nose. So all of the picture on the right, all of these eye movements you see here, that's kind of what those muscles are contributing to. So moving into vision therapy, what is vision therapy? So it's an individualized program of procedures or exercises for the eyes, specifically to support the connection of the eyes to the brain. I have in quotes there the procedures and exercises. Reason being is exercises people really attribute to strengthening. And what we're not necessarily focusing on strengthening. In many cases, the eye muscles are strong, but what we're actually doing is trying to improve the connection between the neurosensory and the neuromuscular pathways of the eyes so that they can team up and work together. So in general, what does vision therapy do? It's going to help patients develop or improve fundamental visual skills and abilities, improve visual comfort, ease, and efficiency. It's going to change how a patient processes or interprets visual information. And we're going to try to improve deficits in balance and mobility. We can all appreciate if someone's not able to accurately take in their world and their environment, it's going to have a profound impact on their balance and their mobility and ultimately their safety. So that really has to be at the forefront of our mind when we're treating patients with any type of visual dysfunction. So in terms of who's going to benefit from vision therapy, it's going to be anyone who experiences any of these list of symptoms, and this is not an exhaustive list by any means, but this is kind of the most common complaints that we will hear. And ultimately, we want to see if these symptoms are having some type of impact on their ability to participate in things like self-care, school, work, or driving. And again, that list is not limited to just those things listed. So typically, a lot of these patients who come in, they'll complain of headache, sensitivity to light, dizziness, double vision, blurry vision. They'll feel like they're often having to close one of their eyes. Their eyes will feel tired. When they're reading, they're going to feel like they need to use a finger to guide them along. And then within that reading aspect, oftentimes people will say that they can't tolerate sustained periods of reading. They'll be omitting or skipping words. They'll have poor reading comprehension and moving their head excessively when reading. So for the purposes of this presentation, we are focusing on vision therapy for someone who has had an acquired brain injury. There are some other kind of elements of vision therapy and populations of people who benefit from it, but for this presentation purposes, we're focusing on brain injury. So the visual system is widely distributed in the brain, which we talked about earlier. It's integrated in more than 50% of human cerebral activity, and it is fundamental for the interpretation and the interaction with our environment. So in terms of prevalence, the numbers are pretty vast and they vary, but somewhere between 50 and 75% of people who suffer from acquired brain injury experience some degree of visual dysfunction. A study that was conducted by Sandotel, and that was strictly with the stroke population, found that at least a quarter of that sample considered that their visual problems had reduced their quality of life or increased their disability. So it's a pretty large group of people to say that, you know, just vision problems alone are impacting to that level of dysfunction that is causing them disability. So it kind of just further shows why this is an important thing to get our patients involved with as soon as possible. Another study done in 2017 by Berthold and Lissette found, so that what they did is they took a population of people, and it was just generalized acquired brain injury, and they asked them the very basic question of, do you feel like you have any visual symptoms? Of that group of people, 54% replied yes and 46% replied no. Even if they replied no, they continued to kind of keep that sample, and then they asked them specific questions related to visual dysfunction, like, do you have reading difficulties? Do you have a field deficit? Do you have light sensitivity? Do you have blurred vision, double vision? And what's interesting with this is you see that our numbers get much higher. So even those population of people that said no, well, now they're admitting to these other areas of difficulty. So what I take from this is people often really attribute visual symptoms as purely acuity. Can I see or can I not see? We often don't think of all the parts that our visual system contributes to in our life. So by really asking these more specific questions, it can be really beneficial to really teasing out some of these people's symptoms and how we can best help them get the services that they need to hopefully reduce their level of dysfunction and disability. So like any interdisciplinary team, you see a lot of pretty common players in terms of who is contributing to somebody who it requires vision therapy. And again, this is kind of, in general, the acquired brain injury population. You're going to have your neurologist, case management, PM&R, speech OT, physical therapy. But specific to somebody who would benefit from vision therapy, we want to have really specifically two key players on board that we would not typically see if someone didn't have vision symptoms. And those two people are a neuro-optometrist and a neuro-ophthalmologist. So people often ask me, what is the difference? How do I know who to refer to? So a neuro-ophthalmologist is going to be mainly focused on diagnosis. So they're going to give the issue a name, they're going to measure it, and they can sometimes provide information about prognosis for recovery in general, but they're not trained on rehab strategies. Neuro-optometrists, on the other hand, they can diagnose if needed, but they're not the specialists in that. But they focus way more attention on the rehab strategies. So whether it's vision therapy and recommendations for that, whether it's a prism lens or a tint in their lens, something that they can do to their actual glasses to improve their symptoms. And they work alongside vision therapists to help guide that treatment progression and make sure that us as therapists, we are treating the patient appropriately and progressing them appropriately. They have a great understanding of the visual function and its relationship to ADLs and mobility. So, that being said, why do we often not hear about a neuro-optometrist? It's kind of the story of my life, that question. Ultimately, it's a highly specialized kind of track that optometrists go through. Very quick story. I have a friend who is in optometry school, and I say to her, you should go into neurooptometry. And she's like, what the heck is that? So their own people don't even know kind of what they do and what their specialty is and how much they help with somebody who is having visual dysfunction after a brain injury. So because I think they're very, not as popular, we're often not getting the right referrals to them. People are often going to the neuro-ophthalmologist route, especially our neurologists and our other physicians. And then in addition to that, a huge downside is often they are an out-of-pocket cost. So really what I hope that most of you are able to get out of this is it is an out-of-pocket cost, but being able to advocate for the benefits of their services is something we should really be doing right off the bat. And my hope is, if they hear it 3-4 times, finally they're like, all right, maybe I really need to make this a priority. We know that cost is such a concern to people following a brain injury, right? So much of their life has changed. They might need other equipment. So really prioritizing where that is, it helps to be able to educate them and advocate for why this is an important service and someone that they should be seeing and they should be frequently following up with. And that leads us then into vision therapists. So a vision therapist can be either an OT like myself. There's also a certificate program through some of the optometry schools where you can become a certified vision therapist. You're going to often see them working in a neuro-optometry practice directly with the doc. In a perfect world, us as OTs, we'd also be working very closely to a neuro-optometrist. Oftentimes that just does not work out. So I myself at least make sure that the neuro-optometrist that I send people to around here, I'm always kind of checking in with them via email, making sure that my treatment plan matches what they think we should be doing and that our evaluations match. And we are looking at a lot of the same things, but they have much more high-tech equipment to really measure and track progress that we don't have access to. So in terms of my evaluation process, I like to start with some type of symptom questionnaire. That way it gives me a sense of how these people are feeling about their vision symptoms. I have people that I look at that I can tell there has to be some profound issues with their eyeballs, and they will go along saying everything is fine. So am I really going to mess with that person? That's kind of one of the questions I have to ask myself often. So I want to know what they feel. And I will show you a copy of this symptom questionnaire later in the presentation, just to give you a sense of what types of questions it's asking. We're also doing just general medical history, so any neurosymptoms prior to the brain injury, When was the brain injury? Was there a loss of consciousness? Excuse me. And if we're talking about concussion, is it the first concussion or is it the fifth concussion? Because that's going to play a large role in kind of what we expect in terms of disability. As we know, post-concussive syndrome, it gets a lot more common the more concussions that we experience. I typically start by looking at someone's acuity, then go into their alignment, then their ocular motor skills, which is for their ability to fixate, their ability to move their eyes back and forth, and then jump from target to target. We look at visual fields, and then we're going to look at their ability, their fusion. So that's kind of another word for that is eye teaming, right? So there's two eyes working together. Typically, this is going to last about 1 to 2 sessions for me to get through my evaluation process, and then we move towards treatment. For the purposes of this presentation and just to maximize the understanding of the deficit and then its relationship between the evaluation and the treatment, we're going to discuss a topic and then go right into how it's evaluated, how it's treated, and then kind of move on to the next topic. So in terms of our treatment, our goals of treatment is we want to improve the speed, accuracy, and integration of the ocular motor functions. And then above everything else, I want to try to reduce their symptoms. So I want to improve safety, and hopefully that's going to increase their quality of life. So acuity. Acuity is what most people do know about in terms of vision, right? So it's just the clarity of our vision. And we look at this from a near and far perspective. So near, we're looking about 15 to 16 inches from the nose, far as about 20 feet away. And we use that typical Snell and eye chart that you see in the eye doctors. But in terms of what this really means for vision therapy, it doesn't really mean much at all. I am not treating somebody's acuity issues. If somebody has an acuity issue, I'm going to refer them to the right people to then help them provide a lens, whatever it may be, to help with that acuity issue. Why I care about acuity, though, is because it can have potential impact on my future testing, so it's something I need to be aware of and note in my evaluation. The other major thing with acuity is, as much as we don't treat it, there are other therapists out there. There are low vision therapists. So if somebody is, to the point that they're, near blindness, I can also educate them to what else is out there and kind of make recommendations of referrals of who may be better suited to treat them and help them kind of learn compensation strategies. So then moving into eye alignment. So our eye's alignment, if something is off, it's typically caused by a weakness of the eye muscles. And that can be because of a brain injury or infection, specifically to the cranial nerves. It can also be something that you are born with. So we look at testing eye alignment 2 ways. And one is for testing what's called atropia, which is in this top section of the picture. And that's going to be a more severe dysfunction. The other thing is called aphoria, and I'll go into kind of the naming of it and what that means on the next slide. But what we're looking to see when we're testing for alignment is there any movement of the eye when one or the other eye is covered? And that's going to tell us, that's going to indicate that there's some kind of tropia or aphoria. Now, you can see with atropia, this is going to be, this picture on the left is going to be their starting position. So I'm going to look at someone and know that there's definitely something up with their alignment. It's much easier to identify. I just need to figure out how I'm naming it. And that's what I'm doing with that cover test. On the flip side, this cover-uncover test, you'll see they're starting, their eyes in the starting position looks relatively normal. So it's much harder to detect, and it takes a little bit more of a skilled eye to kind of really see what exactly is the trouble and how we're going to name it. So aphoria is going to be a misalignment of the eyes that only appears when binocular viewing is broken and the 2 eyes are no longer looking at the same object. So again, much harder to detect. Opposite of that, the tropia is going to be a misalignment of the eyes that are always present. So these pictures here on the right are all examples of a tropia. And then in terms of naming it, that kind of word in the prefix in front, it's going to be dependent on which way the eye is resting. So in ESO, it's going to be the eye is turning inward. EXO is going to be outward. Hyper, the eye is turning up, or hypo, the eye is turning or resting down. And that's just going to help us to figure out where the muscle issue and imbalance is. So in terms of treatment of an alignment dysfunction, a mild dysfunction, which is going to be more so that phoria, exophoria, we're going to try to strengthen the muscles of impairment. And we're going to be starting with just that affected eye. Once we're able to get that range of motion, then we're really going to build up the endurance of them being able to stay in that field. And then we're going to go back to incorporating both of those eyes and see, can they move together? Can they scan and do more dynamic movement in that field that is weak? Severe dysfunction, meaning more of those tropia, oftentimes they can do something surgically. This is especially in children, they're more inclined to do. It does have a high rate of failure, so it's kind of, there's a lot of pros and cons you have to weigh. Your other options are some kind of prism lens, which we'll talk about a little later on, that can help redirect the midline of the eye, or we look to promote suppression. And we're going to talk about suppression more in detail, but essentially you're teaching the brain to turn off that image that that eye is bringing in, that impaired eye is bringing in. All of those things are going to really be led by a neuro-ophthalmologist or neuro-optometrist. But what I can do is I'm trying to then treat the secondary impairments. So if they're having double vision, if they're having eye strain, headache, I'm trying to give them options to for compensation to and remediation for improving on those symptoms themselves. So then moving into our ocular motor skills. So this is eye movement skills. So there's three main things that our eyes are able to do. Fixate is the first and most basic ocular motor skill. It's the foundation in which our other ocular motor skills are based on. And essentially it is the ability to direct and hold a gaze steadily on an object in view. Pursuits is going to be smooth eye movements that allow your eyes to follow a moving target. And then saccades are going to be quick, simultaneous movements made by both eyes moving together, and they're shifting from one target to another. And the targets tend to be further away, and that really is what differentiates pursuits and saccades. So I did have a couple videos, but I think unfortunately they're not going to be working today, so I can always send them in an email to kind of show what this looks like. But essentially when we're looking at pursuits, we want to use, oftentimes we'll use an H or an O pattern, some people use an M, and we're just looking to move their eyes through all their fields of vision and all their planes of vision. So if we're seeing any dysfunction, meaning that they're having a hard time either holding on to the target or there's a lot of jerkiness in the way their eyes are moving, we're then going to kind of dive into that a little more and perform a more thorough assessment within that plane of movement. We need to be looking at these skills in both the horizontal and vertical planes. And then we're also looking, are they consistent or do they improve over time? And are they able to disassociate their eye movements from their head? So can they move through all those planes without their head moving in addition? For saccades, oh, and I forgot to mention this on pursuits. So fixation is going to be secondarily assessed while we're looking at pursuits and saccades. We're going to see if they can hold their eyes on the target. If that alone is a problem, we know right off the bat that that fixation is an issue, and that's really where we need to start. So for saccades, we're holding two targets in front of the patient. Again, about 1.5 feet on either side of their midline. And we're asking them to change their gaze from one place to another on our command. And what we're looking for here, is there any undershooting, so a pause where their eye kind of stops and then they move towards the target, which is called a hypometric saccade, or an overshooting. So their eyes go past the target and then they have to pull them back. Same thing, we're assessing this horizontally and vertically, and we can evaluate at various speeds. Just to check in on if it induces any symptoms, and then if it changes their tolerance. So nystagmus was mentioned briefly, and it's something that we see with multiple diagnoses, so I just wanted to touch on it really quick. But nystagmus is going to be characterized by an involuntary rapid eye movements from side to side, up and down, or in a circular motion. It can affect one or both of the eyes, and people tend to report blurred vision, light sensitivity, difficulty seeing in the dark, or impairments in their balance. There's two main types of nystagmus. One is optokinetic, which is eye-related, or one is vestibular, which is inner ear related. So we will not be touching on the vestibular side of things. If I notice that it seems to be a vestibular issue, I'm then going to reach out to some of my PTs and ask for their opinion on that, because I'm not treating that in vision therapy. All right, so once we determine that they have some type of dysfunction in their ocular motor skills, what are we doing to treat it? The nice thing about dysfunction with ocular motor skills is it's really low tech in terms of what we can do to help them. So it's not going to cost a lot of money. It's easy to carry over as a home exercise program if people get really good with it. So top left is something called column jumps. This is specific to working on those saccades. If someone has an issue with those saccadic eye movements. And essentially those column jumps, it's 10 columns across, 10 rows down. And the most basic form of doing this is we ask them to jump their eyes from column 1 to column 10, read all the way down the row, then move in one column on either side, so it would be column 2 and 9, 3 and 7, or 3 and 8, 4 and 7, 5 and 6. And we're looking for how long it takes them to do that. We're looking for any skips or inaccuracies or deviations from the line, whether it would be, again, vertically or skips horizontally. We can also kind of adjust this if someone also has a scanning issue or a visual field deficit. There's a lot of kind of customization we can do from one sheet of paper, which is really nice. The picture in the middle that looks like a maze is just a maze. So we first start with having that person work through that maze with a paper pencil. We're trying to just have them not move their head and really follow along with their eyes. As that becomes easier, we're then progressing so that they're completing the maze with just their eyes only. And again, that's a lot of that good kind of focused fixation, and then those tracking pursuit movements that we're working on there. The picture on the top right is called line twines. And that's pretty self-explanatory. You're looking at the letter and you're tracking the line with hopefully with just your eyes, and trying to figure out which picture it connects to. This can easily be downgraded. Sometimes we have to start with someone, again, using their finger to guide along. If they're a little further away, we can have them hold a laser pointer and do it that way until they build up their tolerance to doing it with just their eyes alone. The bottom right picture is just a picture of a laser pointer, but what that symbolizes is something called flashlight tag, and essentially the patient will sit in front, the therapist is behind, and two different color lights, and the therapist is moving their laser pointer in all different directions, and the patient is just trying to follow it and track it first with their eyes, and then move the laser pointer to match where the therapist is. And the last picture here is these 3 balls. They're called Marsden balls. And essentially you hang them from the ceiling, and the person is working on, as that ball spins, they're working on just some kind of movement, dynamic movement, and then trying to fixate and focus on a different letter each time the ball kind of reapproaches them. And again, there's a lot of ways to kind of incorporate more mobility and balance stuff with these tasks as well, but I'm kind of just going through them as strictly eyes. And my most high-tech treatment of all is my lovely go-to manila folder. And again, I love this because it costs absolutely nothing. It's easy to, for most people to learn. It's not very complex. It's not, it doesn't come with a whole bunch of instructions. So what I do is I take a manila folder, A, B, C, D on one side, just one letter on the other side, about 1 inch in size. And there's about 6 to 8 different exercises that I can have somebody do with just this manila folder. So this is something I'm introducing really as soon as possible, getting them really comfortable with performing it, and then transitioning this to a home exercise program as soon as I possibly can. So different exercises we can do, I can have them, just holding on just the B side. I'm having them hold that folder, moving it through all different planes, moving it to the left, to the right, up, down, moving it in and out, so towards them and away from them. And then on the other side, we can have them jump their eyes, whether it be horizontally, so D to B, B to D, vertically, A to C, or working in what we call rotary pursuits. So having to move from A to B to C to D in a clockwise or a counterclockwise fashion. So our next topic is Vergence dysfunction. And again, just to remind you that Vergence is an eye teaming ability. So it's an impairment in the eye's ability to work together or team, focus on a near or a far object. And that's going to be differentiated by convergence insufficiency versus divergence insufficiency. It's often going to cause symptoms of blurred or double vision. And if someone has a deficit in eye alignment, which going back a couple slides previous, it's very likely that we're going to see an issue in their eye's ability to converge or diverge. So secondarily, they're going to have a lot of eye teaming dysfunction in addition to the alignment issues. So for convergence, we're talking about when we converge, we're talking about the ability for our eyes to turn towards each other and sustain this position. So that's that classic cross-eyed position. On the opposite end of that, divergence is the ability for the eyes to move out and away from each other, which is typically required when we're looking at an object further away. You will see, I just kind of included some of the other names that you may hear it be called as in case it does come up. And ultimately, convergence or divergence impairments are going to lead to diplopia very often at either a near or far distance. And depending if it is near or far is how we determine if it's a convergence dysfunction versus a divergence dysfunction. This is essentially we're evaluating his convergence and divergence. So what we do is we start with a target at about 20 inches from the eyes. We want to make sure that the target starts as single. If it's double, we need to either bring it in, bring it out to make sure that the starting point is single. We're going to move that target in towards their eyes, and we're going to ask them to tell us as soon as it turns double. Now, this is somebody who has a divergence insufficiency. So you can see his right eye, as we bring that target in, it turns in excessively. And I'm actually just going to rewind just so you can kind of appreciate. So look at that right eye. So it's turning in a whole bunch. And then as we come out, it's kind of getting stuck there. So I would say a convergence insufficiency is a whole lot more common, but I wanted to include this video because it's a great example of someone with a divergence insufficiency. So he was having a whole lot of double vision looking away, looking at in the distance. So what you don't see here is we are measuring, as soon as we get that double, or as soon as they report that double vision, we are going to be taking a measurement at the distance that is at, and then we'll pull the target either away or closer and then measure when they get that recovery point, so when that target becomes single again. Typically, for a perfectly intact person, we would expect the break point, so meaning that target becomes double, somewhere between 2 and 4 inches from the nose, and then it begins becoming single again, somewhere around 6 to 8 inches from their nose. I can't tell you how many times I have walked into somebody's room and, I walked into someone's room, especially right after their injury, and I see that they already have this dreaded eye patch on their eye. So it's often caregivers, both family, but medical professions either too, a first line of defense because the person reports if they have double vision, as soon as you put that eye patch on, they're cured. They do not have it anymore. And why do they not have it anymore? Because we've taken away that second picture. So those eyes weren't teaming, so one eye was bringing in a second picture. So we go and cover that eye, now that second picture is gone. So now they no longer have that double vision. Why is this bad? Because they are never going to get better. This is purely compensation. And what we're doing is promoting suppression. So we're going to talk about that a lot in the next slide or two. But in addition to promoting that suppression, we're also removing that eye completely, right? So everything that eye typically brings in terms of what they see, especially for this guy, his left visual field, he's not going to be seeing as much of that. So we're worried about safety from that standpoint. And anytime we take away one eye, we're also really impacting someone's depth perception. So eye patching should be an absolute last resort. If you take two things home with you from this presentation, if you see someone with an eye patch and you know that they have a brain injury and you know it's because they had double vision, please politely ask them to remove it right away. And please get them into neurooptometry as soon as possible, and then vision therapy. So it should be the last resort. The only time I really kind of give people the green light on using it is for very short durations, and if it's because it's going to impact their ability to engage in other therapies. So if PT comes up to me and says, this person can't even tolerate standing up, their balance is so impaired by this double vision, they're spinning, they're getting nauseous, fine, for short durations, throw it on, and then please make sure you take it off, and please make sure you don't leave it near them so that they pop it on again. Same thing with speech therapy. If they need to read something, if they need to engage in some kind of evaluation tool, again, short durations of time are not going to, make a huge difference. It's really the long-term use of it. So in terms of treating these fusion issues, so again, that eye teaming issues, there's a lot of things that we can do. And this does fall, this is kind of more what I would consider like high-tech type of stuff. So it's things that have to be in the clinic to use. The top left and top middle pictures, those are called traniglyphs. One being a fixed traniglyph versus one being a variable traniglyph. We use these with those red-green glasses, which is pictured there in the middle picture. And essentially, we're moving from the most easiest into then harder and asking them to try to maintain one picture. And you can see if you look at A is going to be the easiest, but something like F, those are really far apart. So we're asking them to try to hold their gaze and keep those crossed over and fused so that they're not seeing that double picture. So it's like an exercise. We're working on their eye's ability to kind of hold that that teaming component. The top right picture is called a Brunelloscope, and essentially it's just another way that we can work on various different dimensions and different pictures to work on that eye teaming, keeping those eyes either converged or diverged as the pictures become further and further apart or closer and closer together, depending on what we're working on. Same thing then kind of that on the right-hand side with the little, looks like lightsabers. They're working on, they're going to hold that right up to their nose. They're going to start at the furthest picture and then see if they can move their eyes in while following the red and the green and having those red and green pictures overlap as they come in. The bottom two pictures are a little more low-tech. This is something that we can eventually transition as a home exercise program. So again, really important that we introduce as soon as possible. The one on the left is called a pencil push-up, and that's just working on shifting their gaze in and out following a pencil. And the middle one is called a Brock string, and they're working to move their eyes from one bead to another. Again, depending on, if we're working on convergence, we're starting at the furthest one and we're moving our eyes inward. And they're just trying to make sure that they're keeping the beads single. As soon as they see double, then we're then backing out and then trying to come back in again and see if we can work those eye muscles to keep teaming up as the target gets closer. Okay, so finally, we're going to talk about suppression. So something's up with this person. You can tell, either their mobility is impacted or you can see that their eyes are just not working and teaming together. But they say everything is fine. So the first question I'm going to ask myself is, could they be suppressing? So suppression occurs when the brain actively ignores all of the visual information coming from one eye to avoid blurring or double vision. So it's actually a really smart and creative compensation that our brain automatically does for us over time when we have this constant blurring and double vision. The reason it's not good is, again, it ignores all that visual information. So someone's depth perception can be really impacted. Their visual fields are going to be impacted. So unless it's really kind of the last case scenario or best case scenario for them to suppress and it's the last resort in terms of treatment, we want to try to correct that. In terms of when am I not going to correct it, if somebody is 3-4 years post-injury, I'm probably not going to try to correct their suppression, because at this point I'm going to have to make them a lot worse first to do the anti-suppression before I can make them better. And who's to say 3-4 years out from their injury, they have the capability to get better. So that's an example of when I'm going to say, you know what, I'm going to really educate and teach those compensations for, if you're actively ignoring your left eye, okay, what do we need to do and what do you need to be aware of? But if someone is really under a year since their injury, or even more than that, but they're really, really motivated and I feel like they're going to carry out their home exercise program, those are going to be kind of things that help me make that judgment. So in terms of assessing, it's really pretty easy. They're going to pop those red-green glasses on. It's called the Worth 4-dot test, and they're going to, you're going to shine that flashlight on the wall, and we are looking how many dots they see. So if they see 4 dots, that's normal. Both eyes are working. If they see any less than 4 dots, so 2 or 3 dots, it means they are suppressing one of the eyes, and that will indicate depending on the color that they're seeing. So if we are going to treat suppression, what we need to do is, it's going to be a lot of stuff with the red-green glasses, and we need to first really work on strengthening that affected or weak eye. So we're first this is another place where we're actually patching their quote-unquote good eye, bringing in a lot of active scanning and visual information into the quote-unquote bad eye, and then seeing how long, once we give them back both eyes, how long can they maintain that binocular viewing before their brain suppresses again? And we're trying to build up on that tolerance. So again, lots of different things we can do. It's mostly with these red-green filters. One cool thing that I really like, there's these red-green playing cards. So it's nice because you can really engage them in just about anything, any card game they'd want to play. But essentially what's going to happen is if you're looking at them without the glasses, it's going to look like that top picture. If they're suppressing the eye that the green lens is over, it's going to look like the second picture down. Opposite, if they're suppressing the eye with the red lens over it, it's going to look like the third picture down. And then if it's normal, it's going to look like that bottom picture. So again, we're trying to see how long can they maintain more of this bottom picture before things start missing again. All right, and finally, we're going to just quickly talk about field deficits. So really, really common in brain injury. So 4 fields of vision: superior, inferior, nasal, and temporal or peripheral. And depending on where in the brain the damage or the injury was, there's a lot of variations in terms of where those field cuts are going to occur. This is just an example of kind of 7 different things, and you can look at the picture later, but it kind of shows, okay, if it happened here, this is what we'd expect in terms of their field cut. So field cuts are pretty prevalent in acquired brain injury. So anywhere between 20 and 50% have some deficit to their field. And the rate of recovery is pretty poor. So this study done in 2016 by Zhang et al. Found that the greatest recovery occurs within the first 10 days. And then it's minimal recovery, kind of what they call minimal, after 10 to 12 weeks. So oftentimes, especially an outpatient, they're really, they're at least 12 weeks post-injury often. So at this point, I can kind of assume that their fields are not going to spontaneously recover anymore, so we really need to work on compensation. And by 6+ months, there's a really poor rate of recovery. So in terms of treatment, like I said, we're doing compensation mostly. So compensation methods tend to be most effective as they help the individual to learn better use of their remaining vision and to overcome that field loss. So what we're doing is we're teaching them to conduct systematic scanning techniques and fuller head movements to improve the detection of objects in that missing visual field. So we're going to start really low level, at a tabletop, just working on that scanning, and then we're going to really try to build them up almost to the point that, they're in a grocery store and there's so much going on and there's so many distractions and they're having to scan for different things on the aisles. Another option, and typically they wait at least a year, if not closer to 2, before the neuro-optometrist will do something like this, but there is something called, there's prism lenses. So there's various prism lenses out there. These are kind of 2 of the most common, and I will say the top one really is the most common that I have seen. So this field expander prism lens that's on the bottom, that's for someone who would have a left homonymous hemianopsia, meaning a left visual field cut in both their left and right eyes. And essentially that prism lens is going and it's grabbing that visual information, not all of it, but some, and depending on the strength is going to be how much degrees of information it's grabbing, and then it's pulling it into their line of sight. The problem, as you can imagine, it can really impact somebody's balance. Somebody can be really thrown off because their world has been shifted, their midline has shifted with this. So we know that most of our patients it's not just a clear cut, okay, you just have a vision issue. They typically have some kind of balance and mobility deficit too. So that's not usually the go-to route. The Fresnel prism lens, which is above that, that functions almost like, I had a patient tell me this, and I thought it was pretty funny, like a rear view mirror. So they have to look into it, and it's going to give them 30 degrees of extra view in that field that they're missing. So they have to actively use it. So it's not going to impact their balance as much because they can avoid looking into it. On the flip side, though, it is really hard to train on because you really have to train them to use it. And people have a hard time. It's not very easy to kind of learn and manipulate. So it takes a lot of training and a lot of time to kind of go through that. Okay, so going into protocols, really what this slide shows is there is no protocol. It's something that is, there's a lot of different viewpoints on it, and there's a lot of different information out there, but I included a few, most common kind of what we hear in terms of payer sources. So the VA, in 4 to 6 weeks of 1 to 2 60-minute in-office visits plus a daily home exercise program. However, a lot of their research is related to mild TBI, and they are also getting this population of people on like day 3 of their injury. So 4 to 6 weeks, maybe in the most acute stage, maybe you are making a much greater impact, but most of these people are not coming into outpatient therapy within the first week or 2 of their injury. So then you have something from the American Association of Pediatric Ophthalmology and Strabismus. They talk about weeks to months, so what the heck does that mean? Optometry and Vision Science talk about weekly 60-minute in-office treatments plus a home reinforcement for up to 36 visits. So if you're doing it 1 time a week, you're almost into 8 months. And then Aetna is, so it's not enough, but they are one of the few who will pay for purely vision therapy, and that's going to be by those certified vision therapists. Typically, as an OT, we have a little bit more wiggle room in what we are able to get approved, but they give 12 vision therapy sessions with the ability to request more for additional visits after medical review. So there's a lot of clinical trials and kind of things in place and advocacy in place to try to improve protocols and get that necessary funding, because it can be really pricey, when we're talking about a neuro-optometry visit and monthly follow-ups. So if you feel like you have a patient that has some kind of visual dysfunction, like, where do I start? There's a few great symptom questionnaires that are available on the internet. This is just a copy of that first one. Actually, I'm sorry, it's the second one. So it's the Brain Injury Vision Symptom Survey. And essentially it breaks it down into a lot of different categories, but you're asking them to rate their symptoms from never to always. If they score at the bottom of this, it will say if they score a 28 or over, that is going to be indicative that we should be referring them to a neurooptometrist, and they would likely benefit from vision therapy. You can also go to this link for a symptom checklist. So if you don't feel like, oh, I don't know if I'm quite at the questionnaire, let me just kind of ask this patient a few things and see. They have a list of symptoms there. And then if you want to refer to a neurooptometrist, this is through the COVT, is the College of Optometrists in Vision Development. So it's not to say they have every neurooptometrist out there, but you know that if you find them on that website, they are certified vision therapists and they are specialized in treating people with an acquired brain injury. And then their general website is really great as well. So that's the link there.
Thank you for participating in today's webinar. On behalf of Bancroft Neuro Rehab, we'd like to thank you for participating. This concludes our program.